So good morning, everybody. So before I start my presentation, though, I just want to, this, like I said, this is the third CryptoConference, and we're being supported by UCD and the Mater Hospital where I work are providing the facilities free of charge, which helps keep the prices down. And Invisible International, a number of the speakers here are supported by Invisible International, and then Lyme Research Centre, which is a charity that I set up as lead trustee in Scotland. We're kind of helping to support this project. And I think, we're going to have a chance this afternoon to discuss this, but if you look at the history of, Lyme disease, we've got an organization called IDSA, which I'm a member of, and I think some other people who are here are members of as well, but they have a very traditional view of Lyme disease, tick-borne infections, and it's a long challenge to get them on board to even address the discussions that we're having yesterday and today on the complexities of tick-borne infections. And there's a second group called ILADS, which actually is a group of not specialists necessarily, a lot of general doctors, a lot of different types of doctors. And I think the big gap that we really have in terms of moving the agenda for tick-borne infections together is we don't really have a good supportive scientific body, to help us, with advancing the issues of Lyme disease, So I just think at the end of today, or during the discussions we have today, I think part of what we need to do is we want the science to win the day, but we have to get the science out there. And I think Leona Gilbert has said this as well. We actually have to just change the whole message, that's out there about the complexities of tick-borne infection. So there's a scientific agenda, and there's basically a media agenda, and there's a educational agenda to many different levels, to the public, to the patient groups, and even to the governing bodies that basically control the monies for research. Quite interestingly, one of my interests historically has been mother-to-child transmission of HIV, and when I was in America, I showed up as a fellow, as a NCHD to the NIH, and I said, I have this idea for doing a study on the mother-to-child transmission of HIV. I showed up to the National Institute of Child Health and Development, and this was the early days of HIV, and they took it on board. They put huge amounts of research into it because it was a new area. It was an undiscovered area. And some of the people who still work for NICHD, who are the program managers, I approached them a few years ago about saying, let's get congenital Lyme, let's get Lyme on pregnancy on the agenda of National Institute of Child Health and Development. Let's get funding, let's get support to better understand it. And he basically said, if you look at the pediatric Red Book, the American kind of Bible that pediatricians use, it doesn't even mention congenital Lyme as an entity. So you can't advance, research funding through the NIH if you don't even have recognizing of this condition. So I think and we all know that we've seen, I presented previously in congenital Lyme, and there's others who are better experts than I am. There's hundreds and hundreds of publications out there in congenital Lyme, and how the textbooks and the pediatric Red Book don't even recognize that it exists is we all say it's a puzzle. There's lots of explanations or conspiracy theories and all this kind of stuff, but we actually have to find a way of moving forward the science and getting to the influencers, to support our agenda moving forward. So I think at the end of today, we will be having that discussion because right now we're a small group. I think we're right in terms of our mission, in terms of our views on things, but look out there. Patients are suffering. there's a lot of missed opportunities. So I think I'll move ahead with long COVID now, but I just want you to all in the audience today, on those on Zoom, just be thinking about this. What can we do to move the agenda forward with the whole scientific agenda of tick-borne infections? So I'll move on to my most recent kind of disease area, which is long COVID, pathogenesis and treatment options. And this is basically, I have no disclosures. And let me see if I can.
Objectives of this presentation to better understand the clinical findings in both acute COVID-19 infection and those of long COVID, to understand the definition of long COVID.
Oh, this was
Give an understanding of a selected literature review of the findings and persistent manifestation.
There we go. That's fine. I think we're okay now. I think one of my slides was from a previous pre-recorded presentation. So anyway, we're going to be talking about long COVID. We're going to talk about pathogenesis. We're going to be talking about possible treatment options. And if you look across the road here, there's a brand new building at the Mater Hospital, and that is the new National Isolation Unit for Ireland. So, we are the highly infectious disease unit for Ireland. So if any Ebola cases or highly infectious diseases cases come, they're managed in this unit. And I was director of that unit from 2010 to 2018. And subsequently then, when COVID hit Ireland, we were the first to admit the COVID patients, So the first patient was admitted to the Mater Hospital with COVID in the 2nd of March, 2020. And these were Irish who'd been off skiing in northern Italy, and they brought COVID back with them. And then there was a few Aer Lingus crew that had gone off to a retreat in Italy as well, and they all got COVID and came back. So they were all brought to the Mater Hospital. None of us used the appropriate precautions. Many of our staff ended up becoming infected. And then we were really the epicenter for the first wave of COVID. Most of the patients were affected in the North Dublin region. Most of our staff became infected. And then subsequently, we developed a long COVID clinic because.
So what is long COVID also known as?
So this is long COVID, I guess. So long COVID, the accepted description of long COVID is 3 months after your COVID infection and you're still sick. So that really is the definition. And it was very clear in the early days who had long COVID because we had a PCR. They were sick either in the hospital or at home. And then 3 months later, they were still very, very ill. The challenge today is there's lots of COVID going around, but nobody's getting tested. And then they have this mystery illness, and it's even more of a challenge now than before. So we were able to get funding through the HRB, the Health Research Board of Ireland, to study long COVID. And I established then, with the funding from the Health Research Board, I established kind of a long COVID clinic. And we actually then started doing analysis of the patients that were coming through the clinic. And this is just one of the first publications actually of actually patients who were admitted to the Mater Hospital with COVID infection. And this was Brendan O'Kelly is one of my MCHDs, one of the junior doctors, fellows at SBRs, as they call them in Ireland. And he's used the data from this work for his MD thesis. So the first publication then was looking at the clinical course of patients hospitalized.
This is a slide that represents some of the early. This is a CDC.
So unfortunately, this is. I think maybe I'll just let them talk. So this is the first 100 patients admitted to the Mater Hospital with COVID-19, and we all know that people have respiratory symptoms. But if you look additionally, then a third of patients had gastrointestinal symptoms, and a third of patients had neurological symptoms. And this was actually 3 years ago, this was a bit of an eye-opener. We thought the heart and the lungs would be the disease, the conditions that would be the organs that would be severely affected. But the heart healed, the lungs healed, and subsequently what we found out was the brain didn't heal. So this is really the challenge. So if you look here, that people, loss of smell and taste is classic, but also reduced consciousness, headaches, myalgias, fatigues, were all a part of acute COVID. And then subsequently long COVID, the predominant symptoms were neurological or central nervous system, autonomic nervous system.
This is a CDC.
And this is also then just a slide from the CDC that expands all of the different signs and symptoms that are associated with long COVID, fatigue, muscle aches, difficulty sleeping, headaches, memory problems, dizziness, now cough, joint pain, palpitations, diarrhea, sore throat, night sweats, tachycardias, fevers and chills. So these are, and there's now 200 different signs and symptoms. And it sounds a lot like Lyme disease when you think about it, and other infections similar to that. Multi-organ, multi-system, multi-pathogenic mechanisms, causing these symptoms.
This is a CD.
Okay.
We were fortunate to be funded.
And then this is the follow-up data that we have, and we called the study that we were doing was called the Anticipate cohort, and this was a 1-year follow-up of patients post-COVID-19 in our long COVID clinic, and we kind of included 150 patients to do this analysis, and we did questionnaires on them, examinations, follow-ups every 3 months. So we have data longitudinally on these patients. And actually now I have a summer student working this summer doing a 3-year follow-up of the patients. So we're going to do a repeat questionnaire to see how many people are still sick 3 years down the way from COVID.
We were fortunate.
So this was a prospective longitudinal study done through the Mater Hospital. They were laboratory confirmed or clinical COVID. Almost all of them were PCR positive. Our clinic then, we saw 20 to 25 patients weekly, and actually I've personally seen 1,700 people in follow-up for the COVID infection, long COVID. So some of them were previously hospitalized, some of them were outpatients who never ended up in the hospital, some of them were GP referrals, and a lot of them in the first wave were actually healthcare workers, care workers, people, staff working in nursing homes who were infected, with COVID.
This is one of our.
This is the publication. Anticipate longitudinal follow-up of patients post-COVID-19. It was published in the International Journal of Infectious Diseases, and like I said, it was put together by Brendan O'Kelly, the registrar.
This is one of our. So the SF.
What we did was we did evaluations, and one of the questionnaires was the SF-12, and that has 2 different parts: a physical component score and a mental component score. And an average score for an average person is 50.
So the SF-12.
And this is basically looking at SF-12 outcomes at 3 months. And just so if you look at the population in the first wave, it was 48% men. The average age, was mostly people in their 20 to 40 age range. 43% of them were hospitalized, but 57% were not hospitalized. 14% ended up in the intensive care unit. And then when we saw them at 3 months, that 70% still had symptoms at 3 months. And then this is additional data at 3 months and then symptoms at 1 year. And if you look at 3 months, the symptoms were more shortness of breath, fatigue, chest pain, headaches, cough, generalized body pains, and anosmia. We all know that cranial nerve 1 and 2 is affected. But then it's symptoms at 1 year. A lot of, like I said, a lot of the heart and the lung things had disappeared, and it became a brain thing. So fatigue, decreased concentration, some shortness of breath, some cough, but pain, neurological issues, headaches, anosmia, chest pain were still an issue. And interestingly, we were looking for cardiac cause of the chest pain, but recently it's been really become clear that it's just not cranial nerve 1 and 2 that is involved. There's also the vagus nerve, cranial nerve 10 and 11. And a lot of these chest pain symptoms and ongoing symptoms that people have are due to other cranial nerves involvement. So these symptoms, and we didn't know that back then. This is just something we've kind of learned over the last year. This is then looking at SF outcomes at SF12 outcomes at 12 months. And I think just that the important take-home message.
To summarize the results.
The important take-home message is that at 1 year, 10% of people are still significantly unwell with long COVID. And other studies there's bigger studies that have done that. There's another study done from Cork in Ireland. There's studies coming out of the UK. There's studies from all over the world that basically 10 to 30% of people following a COVID infection are still unwell. And if you think of Lyme disease and you think of the definition post-treatment Lyme disease syndrome, what are we seeing? We're seeing 10 to 20% of people are still unwell following their initial infection.
Just to summarize,
some of these,
the next study that
I'll make some of these comparisons as we go through the presentation. We also kind of did an analysis of mental health and alcohol use among patients attending the post-COVID clinic. And this was actually done we had kind of a GP arm of this study. One of my colleagues, Professor Walter Cullen, Professor of Urban General Practice at UC.
The next study,
and this
summarize the results then.
Really is that if you look at 1 year down the way, and these patients followed in the long COVID clinic, 18.3% of the participants had moderate to severe signs of depression for at least 1 year. 13% of participants had moderate to severe anxiety for at least 1 year. 21 participants had findings of PTSD for at least 1 year. And then interestingly, 72% of participants had concerning alcohol use at 1 year. Now, this doesn't necessarily mean that they were drinking excessively of alcohol. People have always questioned this, but they were turning to alcohol as a coping mechanism for dealing with all these symptoms. And I would say I've got these people who were previously very placid, unconcerned about the world, and then 15% of them have this unexplained anxiety. So where is this anxiety coming from? And the history of Lyme is half of our patients end up getting psychiatric diagnosis and sent to psychiatrists. The story that we're seeing with COVID and long COVID now is in a lot of the public clinics in Ireland is they're seen one off, you're anxious, you're depressed, you're this, you're that, and they're discharged from the long COVID clinic and they're sent to a psychiatrist. But the problem isn't psychiatric, the problem is neuroinflammation that's triggering these psychiatric manifestations. But these are the findings from the long COVID matter. Additionally, and one of my registrars this year, we did a retrospective analysis of patients admitted to the ICU and the HDU, the high dependency unit. And the title of this paper that has just been published, it's online right now. It's officially going to be out in July of this year. Is the reactivation of herpes viruses in severe COVID-19, a retrospective analysis of a critical care cohort. So we had about 295 people that ended up in our ICU with COVID in the first wave, and then. Of those, 22% died, and 29% of them ended up being intubated, but the rest of them were on kind of high intensity ventilation. And
the next tab was
and looking at Epstein-Barr reactivation. Now, we don't usually do PCRs for Epstein-Barr virus in patients in the hospital unless they have HIV or AIDS, or unless they're transplant patients. But for some reason, the ICU, they did Epstein-Barr PCR, and of those where they did do Epstein-Barr PCR, there were patients positive. 27 of the 205 patients that were tested for EBV viremia and 7 of the 26% had detectable EBV viremia. And then when you actually
was react.
we actually looked at the lymphocyte counts in these patients, and patients who were Epstein-Barr virus negative to Epstein-Barr virus positive. There's a trend towards lower lymphocyte counts. There were small numbers, but it wasn't statistically significant. But I think it is clinically significant that I've never seen Epstein-Barr reactivation except in AIDS and transplant patients. Here we are, previously healthy acute COVID infected patients. So Epstein-Barr virus seems to be an issue. Moving forward, then with CMV viral reactivation, and similarly, for some reason they did CMV PCR on a subset of patients, and 67 of 295 patients were tested for CMV viremia. In 15 of 67, 22.3% had detectable CMV viremia. We did some analysis on that. When we looked at those who had CMV reactivation, well, 3 of them were chemotherapy patients, which, transplant patients, so you kind of expect that. But 6 of them were just ECMO recipients, and 6 of them had no real significant immunosuppression. So this is another unusual finding to me, to see proven CMV viral reactivation. And I'll give you the analogy that the Lyme community keeps on saying, we think virus is a reactivation, we think that's contributing to patients' chronic symptomatology. I've never seen a publication that really supported that. It's all theoretical. We've never got data out there on chronic Lyme symptoms related to viral reactivation. I guess I'm saying maybe we can use some of the data from COVID and long COVID to make a good analogy. This is what's going on. And then this is also looking at lymphocytes and CMV, CMV positive versus CMV negative, and there was lower lymphocyte counts in those who were CMV positive. Moving on, we're looking at HSV, VZV viral swabs. Just to summarize, 9% of the cohort developed skin lesions, which are either HSV1, HSV2, or VZV. And then, so this reminds me of the days of HIV and AIDS, when we used to see these gay men coming into the hospital, ending up intubated with PCP pneumonia. We saw this reactivation of herpes viruses. We saw all this reactivation of shingles. And I have a long COVID clinic, and I've got 33-year-old men who are coming in to see me with post-COVID 3 episodes of shingles in 6 months, which is quite unusual. I've seen 10 and 11-year-old kids who are getting shingles in the middle of their COVID infections. So we are seeing reactivation of viruses. And the same association is that there's association between reactivation with nadir lymphocyte counts. And I think we need bigger studies actually to show significance, but the trend was there, consistent. Which patients progress to long COVID? It's not necessarily those in the ICU. Anyone can, okay? That really is the take-home message. It's not just those hospitalizations. It's almost as likely in those with mild symptoms. And then people say, do vaccines protect you from getting long COVID? The answer is minimally. So there's some reason that people progress on to long COVID. We don't really understand why. And I kind of just put up a slide of clinical manifestations of Lyme disease, and we looked before, at all of the signs and symptoms of long COVID, and there's a lot of similarities: the general constitutional symptoms, the rheumatological symptoms, the neurological complications of Lyme disease are very similar to a lot of the findings that we're seeing that described with long COVID. Okay.
Interesting.
Okay, and then this is just a slide of the this is just a brain of and this is a PET scan, and many of my patients are having scans done, scans for the long COVID, CT scans, MRI scans. Your scans are all normal, Therefore, there's nothing wrong with you. Which is the story. Go see the psychiatrist. So this is just a PET scan actually, and this is a scan taken from National Geographic, and it just highlighting a lot of the receptors in the brain that are that are affected. And then this is just a review of PET scans of the brain in long COVID, and this is from a journal 2021. And then compared to healthy subjects, patients with long COVID exhibited bilateral hypometabolism in the bilateral rectal orbital gyrus, including the olfactory gyrus, the right temporal lobe, including the amygdala and the hippocampus, extending into the right thalamus, the bilateral pons medulla brainstem, and bilateral cerebellum. So there seemed to be hypoperfusion defects, lack of blood supply to the posterior part of the brain, mostly, some cerebral as well. And these clusters of hypometabolism were significantly associated with the functional complaints, the patients were having, the hyposmia, anosmia, memory, cognitive impairment, pain, and insomnia. And then my pulmonary colleagues were people have this air hunger, and they're working them up head to toe, giving them inhalers, doing pulmonary function tests. The respiratory center is in the posterior part of the brain. The pain centers in the posterior part of the brain. So an awful lot of the symptoms, I think, of long COVID are brain triggered, and they're downstream, kind of signaling. And if you look at what we're seeing with patients with chronic Lyme, I think we're seeing similar things. Then the next slide I have is just a summary of PET scans in chronic Lyme. And there's studies coming out of Hopkins and elsewhere looking at that imaging in patients with post-treatment Lyme disease syndrome. In this particular study, they took 12 patients with PTLDS who had symptoms of fatigue and at least one other finding, memory change, difficulty of word finding. And then they controlled, and they found significant differences in the cerebellum, frontal cortex, parietal cortex, thalamus, temporal cortex, cingulate cortex. So very similar findings on PET scans of the brain in patients with PTLDS and patients with long COVID.
When you look at
and so what happens then, like you said, with COVID infection? So this is a schematic. You get acute COVID, and then some people go on to full recovery. And there are certain factors that predict full recovery, and there are certain factors that might make a difference. There's social determinants, there's severity, there's medical comorbidities, there's certain demographics, women more likely than men, probably people with pre-existing autoimmune conditions, maybe people with previous viral infections, that are more likely to be hit. And then I told you 10 to 20% of people go on to develop long COVID. And what is causing this? And there's lots of theories: viral persistence, ongoing inflammation, reactivation of herpes viruses. There's an element of dysbiosis, in the gut. Your gut is your immune system. 90% of your immune cells are not in the blood; they're in your gut. There's kind of ongoing, theories that microvascular dysfunction may be involved. And acute, in the ICU, in acute COVID, 10% of the patients were getting blood clots. That doesn't happen in flu. 10% of patients in the ICU are getting really unusual blood clots. So there is an element of hypercoagulability in the setting of acute COVID. And now there's kind of, studies coming out to support that even there's microclots that may be contributing to the pathogenesis of long COVID. And then there's all of these other, autoreactive immune responses, autoantibodies that people are getting. And I'm seeing lots of people with, rheumatoid factor, ANA positive. And of course, they go to see a rheumatologist and they've been diagnosed with atypical rheumatoid arthritis, and this is post-COVID because they have joint pain and they have a few autoantibodies that have been stimulated by COVID. So this is really the challenge. And this is just another slide that just goes on looking at, the different organs that are involved, acutely and down the way with COVID. And we're seeing, I was just looking this morning, in Sweden, there's a high incidence of diabetes in children, one of the highest instances in Europe, because they didn't lock down in Sweden. I'm not saying that they were wrong not to lock down, but one of the consequences has been a higher incidence of childhood diabetes. So COVID affects so many different organs, and we're seeing so many different complications down the way, from the coagulation problems to, to reproductive system problems, to neurological problems, to GI problems, and then, like I said, endocrine problems, including, diabetes. And I've seen patients with long COVID develop hyperthyroidism, hypothyroidism, all sorts of endocrine complications, because the virus is obviously targeting these organs. And then this is just another, like a schematic looking at, thinking about what's happening: immune dysregulation, microbiota dysbiosis, autoimmunity and immune priming, blood clotting and endothelial abnormalities, dysfunctional neurological signaling. And I think that really is the problem: dysfunctional neurological signaling. And I think that's, we've not done the studies on Lyme and co-infections and what's causing PTLDS, but I think there's huge money's been thrown into COVID and long COVID, and I think we can learn a lot. Not just to learn a lot, but also maybe to start thinking about designing better studies if we had the funding, but also to start looking at better interventions, to help these people. And then this is just what's going on at the level of the brain, the different parts of the brain that are affected. And as I said, it's the posterior parts of the brain, hyperperfusion defects that are going on, and lots of theories as to what's going on. Is there a residual virus there, that in sanctuary sites, or is there residual viral proteins, including the spike protein, that's the dead proteins that are left there, and that's the immune system that it's attacking that's causing all of these long COVID symptomatology. So these are just some of the theories: the neuronal damage, microglial damage, demyelination.
This is an interesting
This is kind of a study then that was just published in the British Medical Journal, and it's an update for primary care. And it was put together by a group of primary care doctors and a few other specialists looking at long COVID.
This is
just an interesting. It reviews all the different symptoms and actually possible interventions. But I just thought it also had a few patient accounts of long COVID, accessing services from research interviews with people with long COVID. And it's just interesting that what these people experienced. I had an odd rash for a while. It kept coming and going, very itchy cough, very mild asthma. I started getting odd headaches again, pins and needles, feet going completely numb, all sorts of odd symptoms. I just kept putting it down to grief until a couple of months in, a friend said, "Look, do you think this could be COVID?" The fatigue is literally like hitting a wall. I can't stay awake anymore. It's just like, wow, I have to go to bed. Next quotation, I'd had 11 days of feeling great, and after a particular weekend, I crashed again. And again, it seemed to last for weeks of having these waves of symptoms: shortness of breath, diarrhea, muscle aches, complete fatigue. And these are the kind of symptoms that people with ME, CSF have been going in for decades. And these are the kind of symptoms that our patients with PTLDS have been going through for years. And these are the symptoms that a lot of these people with mystery illnesses that are showing up in my clinic 8 years later, when somebody said, "Oh, you should do a Lyme test," and oh yes, I remember that bullseye rash. These are a lot of the same experiences that a lot of our patients are having. And there's lots of data, like I said, coming out, looking at the neurological complications of COVID, long COVID. And they were being published as early as 2020. And actually, the first study that I looked at that really kind of was the study by Young from early 2021 that basically looked at the hypoperfusion defects in the posterior part of the brain, kind of hypothesizing that was the problem. Then shortly thereafter, the vagus nerve. And I think an awful lot of the symptomatology of long COVID. And I wonder if not some of our PTLDS patients as well. I think the vagus nerve is involved as well. So these are just a number of the studies that have been put together looking at long COVID. So there's lots of data out there. And just
Well, recently,
Scientific American, in February of 2023, Neuroscience, long COVID now looks like a neurological disease, which should help doctors to focus on treatments. And that really is, kind of quite important. So we're getting out there into the scientific community, the general community, which hopefully should impact on the scientific community. This is then a recent study, and I'm just going to kind of summarize a lot of their findings. Different organ targets, and I think, like I said, there's a lot of analogies we can draw from these findings to managing our patients. Long COVID, major findings, mechanisms, and recommendations. And like I said, it's published just this year. So immunology and virology. So there's been studies looking at immune dysregulation in individuals with long COVID, and they found T cell alterations, including exhausted T cells, reduced CD4 and CD8 effector memory cell numbers, that can persist, in at least this study, for 13 months or longer. And studies have reported highly activated immune cells, lack of naive T and B cells, elevated expression of interferons, persisting for at least 8 months. And then, looking at other immune markers, activated B cells, double negative B cells, IL-4, IL-6 secreting CD4 T cells, decreases in numbers of dendritic cells, exhausted T cells, low cortisol levels, expansion of cytotoxic T cells associated with GI presentations of long COVID. So lots of findings. And when I see patients with chronic Lyme, when I see patients with long COVID, I'm doing CD4 markers. And just last week, one of the PTLDS patients, our CD4 count is 140. 140, which is if you had HIV and AIDS, that gave you the definition of AIDS back in the olden days, CD4 less than 200. And then similarly, that was a Lyme patient. And then half of my long COVID patients, not all of them, have primarily CD4, CD8, CD3s. The different lymphocyte markers are affected, and that's probably affecting their immune regulation and also affecting reactivation of viruses. Additional studies then looking at immunology and virology, elevated levels of cytokines, IL-6, TNF, and then persistent elevations of other chemokines, cytokines that are associated with cognitive dysfunction. And then it's kind of interesting when you look at ME/CSF, some of these findings have been found years and years ago with patients with ME/CSF, but ME/CSF patients are still sent for cognitive behavioral therapy, as implying that it's some kind of psychological disorder. Moving then on to the vascular issues and organ damage, that I think that there seems to be, a theory that microclots, are a part of, the issues, and these microclots may be affecting the size and the stiffness of the blood cells, and this may be affecting oxygen delivery. And this is one of the additional theories then, a long-lasting restriction in vascular density, specifically affecting the small capillaries. It's been found in patients with long COVID compares with control, even 18 months after infection. And there's a condition called COVID toe that people end up getting some kind of, it's almost like chilblains, some kind of inflammation. And when you actually see the COVID toe, I showed it to one of my hematology, and he says that this is some kind of a microangiopathic process going on in the blood vessels. I saw one of the first COVID toes in the world. One of my friends in America have a daughter who just graduated from Virginia Commonwealth University Medical School. Her boyfriend in New York was infected in the first wave 2020, moved down to Virginia to live with her, and then broke out in the COVID toe. And they sent me a picture of it. I still have it here. They said, "What is this?" And so I took it to my hematologist. But this, I think this is an example of what's going on with the COVID toe. It's an example of what's going on in the blood vessels of patients with long COVID. Moving on then to neurological and cognitive systems. The possible mechanisms for these neuropathologies include neuroinflammation, damage to the blood vessels by coagulopathy, endothelial dysfunction, including neuron and injury. And studies have found Alzheimer's disease-like signaling in patients with long COVID, peptides that self-assemble into amyloid clumps, which are toxic to neurons, widespread neuroinflammation, brain and brainstem hypometabolism correlating with specific symptoms, and abnormal CSF findings in non-hospitalized individuals with long COVID, along with an associated younger onset and delayed neurologic symptoms. And then multi-lineage cellular dysregulation and myelin loss were reported in a recent reprint in patients with long COVID with mild infections with microglia reactivity similar to that seen in chemotherapy. People who get chemotherapy radiation, they often have extreme exhaustion, kind of called chemo brain. And when you do the scans on those patients, there's very similar abnormalities. And in the first wave, I actually had a number of patients that were admitted to the hospital with seizures as a presentation of long COVID. And 2 days later, their lungs filled up, and we didn't think COVID. Actually, when they came in, I thought they were alcohol withdrawal, That's what the likely diagnosis at my hospital with our demographics in this area. But they presented with seizures, and we did lumbar punctures, and they had a viral meningitis. And I had some patients with COVID, long COVID, go on to requiring shunting, shunting for hydrocephalus. So we know that COVID affects the brain. And I think with long COVID, that's part of the issue. And then finally, ME/CSF, dysautonomia, and related conditions. And I think there's a lot of similarities. Many researchers have commented on the similarity between ME/CSF and long COVID. About half of individuals with long COVID are estimated to meet the criteria for ME/CSF. And in studies where the cardinal ME/CSF symptoms are post-exertional malaise is measured, the majority of individuals with long COVID report experiencing post-exertional malaise. A study of orthostatic stress in individuals with long COVID and individuals with ME found similar hemodynamic, symptomatic, cognitive abnormalities in both groups compared with healthy individuals. Importantly, it's not surprising that ME/CSF should stem from SARS-CoV-2 infection, as 21% of SARS-CoV infection survivors in one study met the criteria for that. And then what causes ME/CSF? We now add COVID-19 to one of the pathogens, but also there's lots of theories: EBV, Coxiella, Ross River virus, West Nile virus. There's lots of these as viruses and bacteria inducing these conditions, but I think, this is one additional thing. And then if you look at what are the abnormalities, same kind of findings. The findings are natural killer cells, T cell exhaustion, other T cell abnormalities, mitochondrial dysfunction, vascular and endothelial abnormalities, deformed red blood cells, reduced blood flow. And then this whole process then is leading to hypoperfusion of the brain. The immune dysfunction is causing reactivation of the herpes viruses. So this is old literature on ME/CSF that's been buried in the literature. And I think it's just coming to light now in the setting of long COVID. Dysautonomia has been long-standing understood in ME/CSF. It's well understood in our chronic Lyme patients. And then finally, mast cell activation symptoms is also kind of comorbid with ME/CSF. And if you look at our long COVID patients, we're seeing an element of mast cell, histamine release, allergic reactions, skin rashes, increased allergic symptoms. People who used to have seasonal allergies now have all year round allergies, And there's an awful lot of similarities between the findings that we're seeing in patients with long COVID, that described with ME/CSF, and then similarly that described with what we've seen with our chronic Lyme patients. So I'm going to move on then just to talk about how I manage long COVID. And when I used to give lectures on chronic Lyme, I said there's three things going on: infection, damaged immune system, and inflammation as a function of this, dysregulation of the immune system. And So I had my own protocol. I used to just treat people with antibiotics for Lyme, and they got better. And when I stopped the antibiotics, they got worse. So I realized really early on, you had to treat the other things. You need to repair the immune system. You need to do things to control, all the other factors can affect the immune system and affect the inflammation that's going on. So I followed my long COVID patients for the first year, thinking they get better every 3 months, every 3 months, every 3 months, every 3 months. And then finally, I just said, we have to do something to intervene, because the magic bullet to cure long COVID is not going to come along for 5 to 10 years. So I started taking most of the stuff I was doing for my chronic Lyme patients, except the antibiotics, because viruses don't respond to antibiotics very well. That's what I was taught in medical school. But anyway, but there still is the issue that much of what we do for supporting patients with PTLTS, we could apply to long COVID. So what is seen in long COVID? Deficiencies of zinc, selenium, magnesium, coenzyme Q10. Studies have been looking at probiotics to speed up recovery for COVID-19. Inflammation, autoimmunity underlying many of the long COVID manifestations. We think that damage to the mitochondria with the crashing that people get is probably an element of what's going on. There may be issues with microclots. There probably is reactivation of other infections in the setting of COVID-19 induced lymphopenia. I actually, when I see my long COVID patients, I can't do PCRs, but I can do EBV and CMV. And I'm actually seeing new EBV and CMV infections in patients. So maybe they're more susceptible to acquiring new infections because they're immunocompromised. Besides brain inflammation, other cranial nerves are involved, not just cranial nerve 1 and 2, the smell and taste, but the vagus nerve. I'm seeing facial nerve involvements. I'm seeing people with hoarseness, cough, yawning, all sorts of symptoms that indicate the other cranial nerves have been involved. And then sympathetic, parasympathetic dysregulation is common.
So,
management of long COVID, lessons from Lyme disease, which I said is similar characteristics. Infection trigger a cascade of disseminated, damage to multiple organs and tissues, a cascade of inflammatory and autoimmune processes. Microbes may cause damage at the mitochondrial cellular level. Patients are often lymphopenic with deranged lymphocyte markers. Lymphopenia causes reactivation of dormant infections. So management must address issue of persistent reactivation infection, deranged immune system, immune crashing, microclots and neuroinflammation, and pacing, not pushing, is required. And people are still recommended graded exercise, which causes total bodily exhaustion and sets you back 2 weeks. But even today, in Ireland, most of the public clinics and even most of the private clinics are still recommending graded exercise.
So
we have better homework on what to do. What helps? I think, you do need to, things affect your immune system. So lifestyle, and complementary alternative medicine, not my specialty, but I think lifetime counseling, diet, sleep, stress management, you need to kind of regulate your sleep. And then interventions to target brain and cranial nerve inflammation, neurorehabilitation. I liken long COVID to concussion, head injury. You need to retrain the brain. Patients with concussions, head injuries have sleep disturbances, memory problems, mood problems, all of the same, alcohol intolerance, all the same things that we're kind of seeing with this. So you need to repair the immune system additionally.
So what?
So home exercises, there's exercises to retrain the diaphragm to breathe. I think the vagus nerve, other nerves are involved. You need to retrain the sympathetic, parasympathetic system. And these are things that were given to me by patients, actually, who got themselves better in the middle of COVID because they didn't have access to any kind of treatment. So there are kind of breathing exercises, meditation exercises to retrain the sympathetic, parasympathetic system. If you listen to long COVID patients, they're oversensitive to sound, noise, tachycardia, jittery, anxious, nervous. They're in fight mode. They need to retrain their sympathetic, parasympathetic system. And there are things to do that. And then there's training on pacing. How not to crash. And at the bottom here, there's YouTube kind of reference here and a slide presentation that was put together by an occupational therapist in Ireland who's worked on the government's stroke program, who's worked in the neurorehabilitation program. So so pacing, all of these kind of things are helpful for patients. We did a pilot study on LDN, low dose naltrexone, and I've used LDN for about 10 years with my Lyme patients, chronic, tick-borne infection patients. LDN has some kind of a anti-inflammatory and immune modulating effect. It's been used long term. And like I said, I've seen it help patients with chronic Lyme. And then about 2 years ago, after a year of watching my patients not getting better, we just did a pilot of 60 of our staff, started them on LDN, low dose naltrexone, and did a questionnaire before and afterwards. And I'll present the results of that here in just a second. So what is LDN? It's it's a product that, like I said, 50 milligrams of LDN is used as an naloxone is used as an antidote for people who overdose on heroin, and it's kind of ambulance crew have it. But at 1 milligrams, 2 milligrams, 3 milligrams, 4.5 milligrams, it seems to have some kind of inflammatory effect and some immune modulation effect. And it's been used in cancer. I used it a long time in the day of HIV and AIDS, where there was no treatment available. It's been used for atypical MS. It's been used for atypical rheumatoid arthritis. It's been used for Crohn's disease to kind of spare some of the biological modifiers. And the thinking is it has certain functions in regulating toll receptors, affecting apoptosis, preventing oxidative damage. And this is just some background information on how LDN.
What is low?
And then this kind of summarizes then what I just said there. It's been used for a number of different diseases. There's placebo-controlled trials to show its benefit in other disease areas. It's a very safe product to use. And you gradually start at 1 milligram, build up to 2, build up to 3, build up to 4.5. And the data that we have was after 2 months of taking the LDN. And we asked people the question, I've recovered from COVID-19, is my health now limiting myself as much? Do I have better energy? Is my mood better? Is my pain less? Is my concentration better? Is my sleep better? And if you look then at the middle, slide here, the p-values, statistically significant improvements in everything with a trend to improvement in mood within 2 months of starting the LDN. And these are, like I said, these are people who are just ICU nurses who for 333 days were just unwell and then just kept on crashing, unable to return to work. So it seems to have some kind of benefit. LDN is one of the interventions, and this just summarizes it. These patients have been sick for 11 months, and LGN reduced symptoms within 2 months. And then, it also improved the parameters of well-being. 6 of the 7 improved, statistically significant improvement, which means you need to do a big efficacy trial to prove it works. I actually went to the Irish government to see if they do an efficacy trial, and they basically said, nope, been done in the UK. They'll do a bigger and better study than anything Ireland could do. And the study going on in the UK is none. There are no studies. So the challenge is we're still running into issues with long COVID, I think, just like we did with Lyme disease, just lack of interest, involvement, recognition by the medical community, how serious and important it is. National Geographic just actually highlighted LDN, an overdose drug shows promise for long COVID patients. And it basically summarizes that what I just talked about. And it actually tells the story of an Irish actor who had long COVID and got better on the LDN, actually was prescribed across the road in the Mater clinic. And then my clinic was not funded. Of course, every act of kindness is punished in Ireland. So they assigned other clinics who are not seeing patients and unfortunately using the long COVID minute for other reasons. So she's been referred to another clinic where she can't get the LDN anymore. So welcome to Ireland, quite a challenge. But it's all over the international press, that National Geographic. It's great to be published in scientific literature, but if you get something in National Geographic, it'll have more impact probably than the New England Journal. But it does look like it's helping the majority of people, and it's part of the solution. And I always tell people, I think there's 4 issues: brain inflammation, immune dysregulation, mitochondrial crashing, and microclots. And LDN's addressing 2 of the 4 of those, and I think it's available. The next thing I think that helps is NAC, tackling the mitochondria. And NAC is a compound, that N-acetylcysteine, that's converted glutathione. And the thinking is that glutathione is deficient in the mitochondria. And we see kids with mitochondrial disorders, muscle disorder, who are followed at Temple Street around the corner here, the pediatric hospital, and the adults are followed here. And we give them NAC as part of the treatment. And kids with mitochondrial disorders, if they do too much, they crash, and their muscles turn to jelly, and they have to lie down. And that's the same kind of symptomatology that our chronic Lyme patients and our long COVID patients do. So I think NAC is part of the solution. In studies, it looked like it improves markers of oxidative stress. It's been used actually in some neurological diseases to help. So I think NAC is part of the solution. Dealing with the microclots, there's products called nattokinase and serrapeptase. And there was a study in America for long COVID where people with really bad long COVID, they gave triple anticoagulants: aspirin, clopidogrel, and apixaban. And those are the heavy-duty drugs that are used for stroke and heart attacks. And people improved. However, a few people get bleeds into the brain, a few people get bleeds into their intestines. So I think it's dangerous to go that route as a rule. But nattokinase has antiplatelet activities. Serrapeptase has, anticoagulant activity. And then in theory, nattokinase in studies has shown to inactivate the spike protein. And one of the theories is that's what's going on in the brain, residual dead proteins that your immune system is attacking. So I just think that my approach then is looking at literature, looking at just experience until we get good studies. I think this is a safe option. And this is just more information on nattokinase, its anticoagulation properties, and serrapeptase and nattokinase impede coagulation. So I think it's a safe option to deal with that. Dealing with the microbiome, this is just, there's a number of studies going on, but I just happen to like this one. Friendly gut bacteria speeds long COVID recovery. So there you go. Everybody needs friendly gut bacteria. Okay, I think that's important. And this is just an observational study coming out of the UK. And the study enrolled 126 people, a third of whom had acute COVID infection, majority reporting a wide variety of longer-term symptoms lasting over 100 days. Results analyzed by university statisticians showed that cough, fatigue, gut, and well-being scores improved. Many said gut symptoms suffered for years to resolve. So I think, no-brainer, deal with the microbiome. And I think that's part of the solution. And then additional, this is I work with the herbalists in Scotland who have kind of given me advice on things. And one of the products that they've kind of looked at is mangofurin. And mangofurin, coming from mango extract, is an antioxidant, anti-inflammatory, immune modulating. And there's a lot of data on in vitro it working in terms of down-regulating some of the inflammatory markers. And it seems to help with the brain. It seems to help with pain. It seems to help with oxidative stress, seems to help with the crashing. And I'm actually doing a pilot myself now on patients I'm seeing, asking them to go on mangofurin and doing a questionnaire on them before and after starting therapy. And these are long COVID patients that I don't think have responded as well to LDN or to some of the interventions down the way. And when I get 20, 30 patients enrolled in that observational study, I'll present those results similar to I did with the LDN. So I think potentially mangofurin is part of the solution. And then finally, there's this hyperbaric oxygen therapy for the treatment of long COVID. And there's actually been some placebo-controlled trials looking at doing this, some early studies, and they seem to show benefit. And this is just one study that was done. They took 10 patients, gave them hyperbaric oxygen, did questionnaires, and there was statistically significant improvement in fatigue scores, global cognition, executive function, attention, information processing, verbal function. And I guess we've used hyperbaric oxygen for lots of different conditions. It's used for wound healing and, people with farm accidents when they've got horrible open wounds in addition to antibiotics. It's been used for neurological conditions. And I think if the theory is you've got hypoperfusion defects in the brain, I think that anecdotally patients report improving. The question is, will the improvement be permanent after 20 sessions of hyperbaric oxygen therapy? We don't.
My suggested protocol.
Suggested protocol. I mentioned it. Go on a multivitamin with coenzyme Q10. Go on a probiotic or kefir. Kefir is a drink used by most of my Eastern European patients. Polish patients use kefir. In Ireland, you can buy really good quality kefir in the Polish stores for chronic fatigue syndrome and fibromyalgia. There's a number of different products to support inflammation, mitochondria, the low-dose naltrexone. For sleep disturbances, I put people on melatonin, and actually the British Medical Journal guidelines for GPs recommend melatonin, not putting people on Zopiclone and Dalmane and all the addicting sleeping pills, because that pushes you to sleep. It makes you sleep the next day, and it makes your brain fog even worse. So melatonin is part of the solution. Maybe you do need to address the mood temporarily. There's allergic symptoms, and people talk about using H1 and H2 blockers. The vagal nerve is involved, and there are vagal nerve stimulators that have been used. We need to do studies on those to see if these are, because some people have those problems. We talked about using nattokinase, sometimes aspirin if they have focal neurological problems, and then working with herbalists, working with non-traditional doctors. People have asked me about medicinal mushrooms that have central nervous system effects, immune modulating effects. They're all possible. These are just the publications that have come out of the matter that we've done so far. And then just finally, the group, I work with a group in Scotland who are primarily medical professionals, GPs, pharmacists, other interested people. And I just want to put a plug for the Lyme Research Centre. So if there's people on the site today that have an interest in, or Scottish based, but actually trying to affect education, science, signage for tick prevention, not just in Scotland, but throughout the European Union. So if people are interested, admin@lymeresourcecentre.com, contact us in that way. So I'll stop now my whirlwind tour of long COVID. Thank you.
Thank you very much, Jack. I can stay here. You maybe have some questions. I have one question for you, because Claude Escargel is a microbiologist in France. He's leading a group of patients who suffered from long COVID. And he said, I'm not sure he has published yet, that people who were treated for their acute COVID with either hydroxychloroquine, azithromycin, or both, didn't go to long COVID, in contrary to the patients who were not treated at the early phase. Do you see that? Or?
That's an interesting analysis. And our protocol at the matter in the first wave is we didn't know what to do. But we actually used, Kaletra sometimes because it was an antiviral. We put patients on hydroxychloroquine, but we actually have the database, from the Mater Hospital. We actually haven't analyzed that database to see if those who received hydroxychloroquine versus those who didn't receive hydroxychloroquine were more likely to go on to develop long COVID. So we can do that analysis because we've got data on about 500 patients who were admitted to the hospital.
Yes.
But Jack, the Cambridge study.
Speak loudly because it's.
Can you hear me on was right. So the Cambridge study showed that you mentioned that the patient said they'd had gut problems for years, and it helped them. Do you know about your long COVID study? Did your patients have gut problems before they got COVID? Do you know? Do you answer those questions?
No, I don't think we looked at that study, but I do think there's, like I said, there's some pre-existing factors that make people more likely vulnerable to long COVID. I don't think we specifically looked at the gut.
I'm curious if you think there may be persistent infection. How do you know COVID there or not there?
Mhm.
I've heard that looking at the spike protein throughout the body, especially in the brain, has that been looked at?
Well, the thing is that is part of the theory. If you look at all the other coronaviruses, coronaviruses were first discovered in 1975 actually, so they've been around for a long time, and the accumulative science is that you don't get persistent coronavirus infection, long term. Like the common cold, you catch 3 common cold viruses. You don't develop a good immune system, but you get repeated coronavirus infections, maybe up to 3 a year. However, there's a New England Journal study of somebody who was in the hospital with COVID who was immunocompromised, and they either mutated their original COVID and persisted, and they were persistently COVID positive for a period of 142 days before they died. So it kind of says that, in some situations, the virus can persist. So the 2 theories are, is there virus persistence in a sentinel site, live virus still there 1 or 2 years down the way, or is this just dead spike protein and the virus died off 14 days into the acute COVID infection? So I just think that there's rare studies have shown persistence, and most studies haven't shown persistence. So I think both are possible.
So I'm just curious, if there might be persistence, then should you include any viral? Should you use Paxlovid, ivermectin with these long COVID?
And people are suggesting that as a study to actually look at patients with long COVID and treat with some of the COVID antiviral, as part of the solution. But people propose using metformin. People propose using, all sorts of different antivirals. Ivermectin. There's all, you could throw 1,000,001 things at people, but I think the studies need to be done. I'm just doing what I'm suggesting right now is supportive stuff until the studies come out, till we have the efficacy trials.
Have you had any experience with guanfacine? And they see there's
exactly. I've seen the data from America on guanfacine, which is used for people 18 and under for some kind of ADHD, some this kind of stuff with NAC. No, I haven't. It's not available here.
And an observation. So with our strokes, because we track Bartonella patients and treatment response, I noticed that those patients who developed COVID had a recurrence of their Bartonella bacteremia. And we also have a spike protein probe. That I noticed in one patient, a young college student with Bartonella, Borrelia, and Babesia. She had very high platelet expression of the spike protein for 4 months after the infection.
And do you think that implies an immune response to an active viral replication? I mean, that's
or at least for a period of time.
Yeah, no, I'm not discounting that. I'm just saying I just haven't seen enough studies to convince myself that I'm willing to just invert with people on Paxlovid as part of the solution at the present time. Other question?
Just some experience from our case. The first thing is that we are testing the long COVID patients also for other infections. And in 30% of the people we find Lyme disease, and in 50% we find Bartonella infection. That is
But is that new Bartonella infection or reactivation Bartonella infection, or what are you seeing?
I cannot tell you if it's reactivated or on. My theory is it's reactivated infection.
And anecdotally, I've seen a teenager who was long COVID come in, and all of a sudden his neurological problems and stretch spot marks in his back that he didn't have before. So viruses I know for sure reactivate.
Yeah.
Should we be treating everybody antibiotics as well for reactivation of bacterial infection? I don't think so, but I think we should selectively think about that as a possibility.
Yeah, and the other thing is also you find in one patient, we find muted coronavirus inside a lymph node, 11 months after the infection.
So coronavirus isolate active coronavirus replication in the lymph node 9 months after the original infection. Right. Okay. So yes, I think the data's out there that can happen. Is there
Do we have any questions online?
So I think we can take 1 or 2 questions online. Is that okay?
Yes, it's okay. Yes, we have that.
So what is the name of the therapeutic? Can the last question and answer be repeated?
Which we're talking about, one of the drugs that we're talking about is that for persistent viral replication, should you be using Paxlovid, which is an antiviral that's used acutely for people who are hospitalized with COVID, who are hypoxic. There's a study going on in America using, how do you pronounce it, guanfacine in combination with NAC, and that is a drug that's used for behavioral problems, ADHD. But like I said, there's lots of studies going on. It doesn't necessarily mean that you can start using every drug from every study that's going on.
Okay, another question.
One more question if you want to read it. In long COVID as well as ME, CSF, and CLD fatigue is cardinal, but what is fatigue if not a physiological regulation process gone wrong? Fatigue manifesting itself inappropriately outside of expected physiological activity is symptom of disease, but what are the neurological circulatory pathways that convey the sensation of fatigue? Change in brain circulation, change in muscle circulation, control.
The vagus nerve. I think this is just more of a comment than a question, really.
Okay.
And I think we all agree that there's similarities. We can learn from ME/CSF, we can learn from PTLDS, we can learn from long COVID, and there's the overlap, probably in terms of pathogenesis and also in terms of symptomatology. And I think some of the treatments can be similar. Okay.
Okay, thank you very much, Jack.